Good morning. Welcome to the GW Epilepsy Grand Round Series. Our speaker today is Dr. Gary Mathern. Gary is the Davis Crandall Endowed Chair for Epilepsy Research at UCLA, where he is professor of neurosurgery and psychiatry. He completed his undergraduate studies, dual majored in chemistry and biology with summa cum laude from Moorhead in Kentucky, and then went to Case Western for his medical degree. He completed his neurosurgical training at UCLA, followed by epilepsy fellowship with doctors Pete Engel and Tom Babb, and then earned a career development award from NIH, K Award, which helped him complete his research training. He eventually became in charge of the Pediatric epilepsy surgery program in 1998 at UCLA. Gary has done exquisite research related to the understanding of pathophysiology of epilepsy in both animals and in human tissue removed surgically from patients with intractable seizures. He succeeded in securing sustained funding, including an R01 grant from NIH to study cortical dysplasias, which was followed by a number of successful renewals. He has trained a big number of trainees, edited for a number of journals, and published over 150 articles in major journals. He has earned a number of awards, including the Ambassador Award from the International League Against Epilepsy and the William Lennox Award from the American Epilepsy Society. And Gary is the editor, one of the editors-in-chief of Epilepsia and Epilepsia Open currently. Today he's going to teach us about treating epileptic encephalopathy with surgery, and you're in for a treat.
All right, let's see if we get all the microphones to work here. Is that working? Hello? Am I good? All right. So, Mohammed, thank you very much, and thank you for the warm hospitality. I'll give a plug to those out there in Cyberland. In preparing for this, I certainly took advantage of some of the material that you've got recorded, and I will certainly say that there's a number of wonderful lectures that you've got, and that I would recommend certainly to all those out there to take advantage of these, and as far as information that you can learn, and several good speakers. I'll see if I can add to that list today. So I'm going to make the pitch today that pediatric epilepsy surgery should no longer be considered a stepchild of adult epilepsy surgery. It really is a field unto itself, and it's been that way now for quite a while. And I'm going to emphasize, I guess there's some obligatory slides. Upcoming events, I guess I'm supposed to mention for all those that need to see it. Under all these, we all have to disclose everything these days for conflict of interest. The only thing I have to mention is I've been on the data management committee for NeuroPace now for a number of years, but I'm not going to talk about NeuroPace. You've had, I think Nathan Fountain was here not too long ago, so you've heard about that. So what I want to cover today is, and hopefully get through these three main topics. One is to really give you an idea of what is different about approaching children for epilepsy surgery as compared to adults. And it's not only the intent, it's what we do and that sort of stuff. And it's dealing primarily with treating the epileptic encephalopathy. Now, I would actually argue that in many ways, adult epilepsy surgery is also dealing with the epileptic encephalopathy, the progressive changes that can occur in adult patients with continued seizures. We just don't admit it, but we should. We should be admitting that really what we're treating is all forms of what seizures do to the brain, whether it's developing or not. We'll talk about define the differences between the goals and the surgical, and then I'll give you an idea of what pediatric epilepsy surgery involves, and then I'll, from a research side, talk a little bit about the work we've done over the years and the most current work, which is the more exciting stuff, and that's the emerging role of the PIK3 mTOR pathway as the genetic underlying cause of most forms of cortical dysplasia and hemimegaencephaly. I also want to dedicate this lecture to the two founding members of the epilepsy surgery program at UCLA. That was Dick Walters on the right and Paul Crandall on the left. It's important to remember that just about every successful epilepsy surgery program in the world has been a marriage between surgery and the neurologist. In fact, as my mentor Paul Crandall told me years ago when I got into this business, he said, look, the surgeon needs to be just as knowledgeable about the epilepsy syndromes as the neurologist if you're really going to understand and take care of these patients, and he was quite correct. So I dedicate it to these two. As part of that, you also have to recognize and understand that all this work that I'm presenting to you is a collaboration. And I'm blessed, I'm up here giving you the talk, but the reality is this work is not possible without the input of a variety of people and a variety of services. Within my own lab, I've got a bunch of people that have worked with me now a number of years. Neuroradiology has been with Noriko Salomon. This work wouldn't be possible without the long-standing collaboration with Harry Vinters at neuropathology and my colleagues in pediatric neurology. And then surgically, at the end of the day, when I take these kids and give them over to the ICU, it's been the ICU teams that fill in when I leave, and the great work of neuroanesthesia in working with these kids. And again, the funding through NIH has been helpful. So what's different about adults and kids? Now, there's a fairly now famous conference that occurred here in Washington, up in Bethesda, at NIH in the year 2000, sponsored by the White House. I think it was Hillary at the time, which was called Curing Epilepsy. It was a focus on the future. And it brought the stakeholders together, the researchers and families. And out of it came the single line that was supposed to be what we were supposed to be doing to treat people with seizures. No seizures, no side effects. That's the goal. Now, and that was great at the time. Now, for kids, the International League had a task force that was organized that got together. And in 2006, I believe it was, we published and said that for the developing brain, this needs to be modified a little bit so that you want to eliminate seizures as soon as possible so that you can optimize the cognitive and other developmental aspects of the kid. This started to bring into frame the whole notion that we were treating this thing, this epileptic encephalopathy. Now, what is this epileptic encephalopathy? And it's had various definitions, but generally most people will concede that it constitutes the progressive impact that seizures have on the developing brain, leading to cognitive and neurologic disabilities which are considered the direct impact of either the frequent seizures or the continuous abnormal EEG activities. These are usually age-related, and most of these are occurring in the developing brain or to the developing brain systems. Now, we know, for example, through various work over the years, that this epileptic encephalopathy has several variables which impact. The first one is the type of seizures that the kids have. And these are Z-scores that you can see on the, I guess we don't have a pointer. Oh, yeah, we do. Let's see. Missed that one, okay.
Can you drag your mouse over? I think it might be on the presenter screen.
Yeah, okay. Yeah, okay. Oh, there it is. You can see that on Z-score. So infantile spasms, which under the old classification were considered a generalized symptomatic epilepsy, that those kids have on average an IQ score that is 3 standard deviations below the mean. And in these particular series, these were kids. Now, so the factors that affect for kids is the type of seizures. Infantile spasms, Ohtahara syndrome, others like that are strongly associated with the epileptic encephalopathy. Seizures beginning before the age of 1 year, a seizure frequency of greater than 1 per day, longer seizure duration, and that's the one factor that as the physicians and clinicians we can impact. We could potentially impact the duration. And kids have tried more than 3 different anti-seizure meds. Now it's important to remember that this epileptic encephalopathy can be quite severe to the point where kids can end up with developmental outcomes and IQ scores around 50. Remember what 50 means. 50 means someone who doesn't really know their name, cannot really participate in the activities of daily living, certainly can't make change for a 20, and are really going to require a lot of help for the rest of their lives for everything that they do. So it's quite a substantial impact. The other important to remember about seizures in kids and all intractable seizures is the rate of death. Now this is not talked about in front of patients, and it really should be, because this comes up more often than not. And in these combined studies, dating back when a bunch of new drugs came online, death from SUDEP or accidents that could be attributed potentially to the epilepsy is significantly higher, and on average is about 0.5% per year. Now that's an important number because if you're a newborn, 0.5% per year. So by the time you get to be age 40, there's a 20% chance that you will die relative to your seizures. And this is part of the formula that you have to consider when you look at the risk-benefit analysis and thinking about what goes into a decision as to whether you do an intervention or not. So kids with severe seizures are at risk for the epileptic encephalopathy and for increased morbidity and mortality. Now, why is that? Well, this is an old slide, but one that's worth repeating to keep people in mind. Remember that when kids are first born, they're really mostly brain, and their bodies are pretty small. And as any parent knows, that brain grows considerably in the first 2 years of life. By the time a kid is 2 or 3 years of age, their brain's achieved 80% of its final adult size, whereas their body takes years before it finally clicks up. This increase in brain volume is not due to increase in numbers of cells, it's due to increased synaptogenesis and maturation of the myelin. So what's a seizure do to that? This is a lot, and in that 2 years there's this huge development. We think about it. A newborn comes out, can barely suckle to keep itself alive. And by the age of 2, you have a walking, talking, running creature which is eager to tell you no for everything that you do. And so what does a seizure do in that situation? Well, think about it. A seizure, in a sense, is like when your laptop freezes up. So it's just too much stuff going on, and your CPU just says, I can't handle this. And so what's it got to do? It has to shut down. So with a seizure, your brain shuts down, and like a computer, you have to reboot. And as you reboot, your computer has a hard time. It's where's my files, where are all the things I'm looking for. And so if you think about it, when you're having 50 or 100 seizures a day, which is not uncommon in these kids, how much of those kids' brains' time is spent in normal learning, and how much of it is rebooting, trying to get itself back together again? So it's this constant shutdown, reboot that is affecting the normal development of these kids, and you have to keep this as this is what's happening. So graphically, I look at this epileptic encephalopathy of something like this. Normally, kids develop at a rapid rate until they get to their full normal IQ. the impact of the seizures is that you do develop. I mean, you see kids doing development, but they develop at a rate much slower than normals. And over time, you see this difference. And it's the space between the normal and their state, which is that epileptic encephalopathy. And again, heading towards IQ scores in the 50 is not unheard of. Now, this approach was attacked or taken on at UCLA by these gentlemen way back in the late 1980s. Don Shields, who is was head of pediatric neurology, not the Don Shields who currently works here. Alan Schumann, who was the pediatric EEG person. Warwick Peacock, who was a neurosurgeon who had come from South Africa to UCLA, but had trained originally up in Toronto. And Harry Shigani, who had access to FDG PET scans. And what they noticed was this. In a certain number of kids, we're going to see if this gets this to work, who had infantile spasms. So this is, for those out there, this is what spasms look like. And this should not be, you should not think of this as anything else but spasms. And this is a medical emergency. I can't tell you how often that kids with spasms get seen by their pediatrician and are still not recognized as seizures until it's often late. Now, infantile spasms is associated then with an EEG hypsarrhythmic feature with these electrodecrements characteristic. Now, Alan, in his study of some of these kids, noticed that several of these kids had, several of these kids had, in their interictal phase, discharges that lateralized to one side or another, which seemed a little unusual to him. This was then joined together. Now, this is an MRI from the 1980s. Yes, it's a real MRI. Our original MRIs were at 0.3 Tesla. But Harry Shigani had access to FDG PET. And on the lower panel, you can see that there were these areas of hypometabolism that were not visible on the original FDG PET scan. And in what is now considered a reasonably landmark paper published in 1990, they reported on 13 kids, of which there was a group of 4 of 5 in which the MRI was normal or subtle, but the surface EEG showed some lateralizing signs, and because of poor control, 4 of these kids went to surgery. And pathology at the time discovered it discovered cortical dysplasia, and 3 of these kids became seizure-free. Now, at the time, this was considered a bit out of the norm. Infantile spasms were thought to be a generalized epilepsy syndrome. How can you treat a generalized epilepsy syndrome with a focal resection? And there were meetings at the time where there were lots of people who would raise their hand and said they would be glad to be an expert witness for a plaintiff if a case ever went forward to court. So it's a bit radical at the time, but has held on. So what does the surgery do? So let's go through, as a surgeon, let me give you a case story. So let's do a story here, and we'll do a story about one kid. So here's William. Now, if you notice about right, his eyes will dart right there. So here's a kid, born, had infantile spasms when he was 6 months of age. And he was successfully treated with ACTH, but then his seizures came back, as you just saw. Now, I come from UCLA, so for those of you who are with all EEG, because Pete Engel trained in England, our EEGs are right over left. Okay? That's the way it is. in the world of, and so what you can see here obviously are seizures that arise from the right side. Didn't respond to several meds, so we went to surgery. And so I ended up doing a right hemispherectomy on him, which was all cortical dysplasia. All right, so he's a year, stopped his seizures. So what happened to him? Well, let's take a look. And thanks to families with compulsive video cameras.
Yes, you want to show me, Kate? How you doing? You say hello? Yeah, you can smile. Good walking on your knees. You're doing a good job. Oh, no. Awesome! High five! You're good.
Would it be okay if I exited to change the volume, or you want to take the volume up? You'd like to up high.
That's as high as it goes.
Okay.
All right, so yes, so is it just motor recovery or are there other things that he can do? So let's take a look again.
Is this the first day?
Yep.
Of what?
For school,
Of school? Are you going to kindergarten? And how old are you?
5.
Awesome. Well, it sounds like a good day. Can I have a thumbs up? Okay, let's count them.
1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12,
Yep, that's what I count.
5, 10,
So he can read,
8,
count.
count, 12.
So remember, this was a kid who, by all metrics, was going to be heading for an IQ of 50 if he had not had an intervention.
15. Yes. Yes.
Now, he's not normal. He's got a paretic hand, a helper hand, as you can see as he moves this stuff around. So he's not normal, but he's a hell of a lot better off than the natural history of the condition, which is why we're doing this. So when we looked at this a little bit more quantitatively, and we did Vineland's, which is one of the only assessments you can use in kids of various ages. And we divided these kids up into those that had active infantile spasms at the time of surgery, those that had a previous history of spasms that had been successfully treated, like William, or those without a history of infantile spasms. And when you looked at their Vineland's pre and post and their differences, what you can see is that the kids like William, who had spasms that was successfully treated, had on average a 14-point increase in their developmental quotients as a consequence related to the surgery. The one that actually did the worst in many ways was those that had no history of infantile spasms. Of interest, the other variable that was significantly impactful was the duration of the seizures. If we had kids who had seizure duration for more than 2 or 3 years, the probability of getting a developmental quotient above 50 became much less. And this becomes then an important element in the decision-making process. If you're going to impact this developmental epileptic encephalopathy, you have a limited time window. So from a sort of point of view, let's go back to the graph. Again, so here's normals. If we had no intervention, this has been where we were headed. With the intervention, we put him back onto a trajectory that led to development, although it was never perfect. So he ended up with an IQ, he's going to end up with an IQ less than normal, but much better than had you not done an intervention. And the difference between early surgery and later surgery is going to have a significant impact in where you end up in the developmental scales. So here's that important message. If you're going to have the impact on the epileptic encephalopathy, you need to identify these kids early, and the intervention needs to be early. How early? Well, I can tell you that in my kids with hemimegaencephaly, which is one of the worst conditions that I deal with, that if I can get them seizure-free by 6 months of age, those are the kids that eventually go on to talk. I have very few kids with hemimegaencephaly that get to talk if we wait 12 to 18 months. So, I hear stories about centers saying you should wait until the kids are a little older so the surgery is safer. I totally disagree. If you're going to impact the epileptic encephalopathy, you should be doing it as early as possible, as soon as you can identify those individuals who are most likely not going to succeed. Now, since that work, others have come out with similar sorts of stories. This was a study that came out in 2007 by the Cleveland Clinic Group that looked at surgery in the very youngest of kids, and there again showed a developmental improvement in a majority of cases if you got seizure control and surgery within the first few years of life. This also emphasizes a couple of the key points, and that is usually the younger the kids you operate on, the more likely they're going to be large resections, like requiring either hemispherectomies for cortical dysplasia and hemimegaencephaly. Similarly, there's some work that came out of that were treating kids with CSWS, and most of these kids had perinatal infarcts. Here again, they were able to show a significant improvement if you were able to get that under control. And I see there's now a paper that's just recently been published in the Journal of Neurosurgery Pediatrics confirming this original finding that comes out of St. Louis. This is, spike waves during sleep is another condition that you might consider. And even in some kids with Lennox-Gastaut syndrome, slow spike and wave. Again, if there's evidence for a diffuse abnormality, especially involving one cerebral hemisphere, and a lot of continuous seizure activity, they are candidates. And so this would be one of the most important messages that I would give from today's lecture, and that is, this is why we're doing this. Now, so one of the things that, just so that UCLA, so traditionally hemispherectomies were all called anatomic hemispherectomies, where you literally took out half the brain. But this was linked with a number of problems, especially something called superficial hemosiderosis and other issues. So beginning with Theodore Rasmussen out of Montreal, there's been a push towards smaller and smaller resections and more disconnections as a way of doing these procedures. And the challenge for each of these is how much ventricle is. When you have large ventricles from an atrophic etiology, then what procedure you do probably is not going to have a whole lot of impact. But when the ventricles are very small, such as a kid here with hemimegaencephaly, this is where it can get to be dangerous. And so some years ago, I worked out a technique that I called the UCLA form of this, where I take out a block of tissue, which is quite literally the central operculum, and then disconnect from within the space. And because at UCLA we had done a number of anatomic hemispherectomies and Rasmussen styles hemispherectomies, we were able then to compare those cases to see which ones were safer. And so this is a chart on blood loss. And the important number here to figure out to know is the number 30. So anything over 30 is a complete blood transfusion for a kid. So you can see that in our hemimeg cases, when we were doing anatomic hemispherectomies, we on average were doing in the neighborhood of 4 blood transfusions to get that kid through surgery. Our single death, operative death, was from a hemimegaencephaly case in which we attempted to do an anatomic hemispherectomy. So by doing smaller resections, we were able to reduce the blood loss significantly to the point where in many circumstances they didn't need blood transfusions. Moreover, when we looked at things like time in the ICU and total hospital stay, the smaller resections were associated with shorter stays and thus less expense. So there are ways to improve what we do if you pay particular attention to detail. From a neuroimaging point of view, one of the things that we learned some time ago was, so Noriko Salomon came to us and we started doing, we'd always been using FDG PET. One of our issues was, could we make it a little bit more sensitive? So by combining, so here's a case, 15-year-old, she had been seizing, she's averaging about 4 a day. She lateralized on her EEG, on her scalp, to the right side in that central area, but couldn't really get more specific than that. Her outside MRIs, which she'd had 3, had all been read as normal. And the first read on this one was likewise normal. But by combining an overlay of the PET scan on top of the MRI, we were able to detect a subtle area of hypometabolism referable to the superior temporal gyrus on the right side. We then combined this with a MEG scan, which localized dipoles to the same area. And so this was a situation where we then, in most centers, they probably would have put a grid in. But instead, with information all conjoined, we did a one-stage operation, able to figure out that area of cortical dysplasia with electrocorticography and make it a single operation, one stop, safer for the kid, life moves on. So you can push your neuroimaging as a way of trying to, again, improve care. This actually got us to the point where we looked retrospectively at how good were MRIs in the community in identifying cortical dysplasia. And what you can see here is that for the type 1 dysplasias, only 15% were appropriately identified in the community imaging. And it still wasn't 100% when it came to our read, but better. And the combination then of the two improved things even much better. All right, epidemiology of, so this is work I was able to do in collaboration with Ann Berg. Ann Berg is a pretty special person. I really like working with her. She had been able to get something done that nobody else had ever been able to get to do. She got 16 of the 17 pediatric neurologists in the state of Connecticut to work together. And for a period of several years, from 93 to 97, she was able to collect all new onset epilepsy cases in the state of Connecticut, which accounted to 613 kids. And over the years, she was able to get MRI scans on 85% of that group. This is probably one of the better cohorts from which to ask some of the questions. She monitored this group for a median of 12 to 14 years, and it's only recently that she stopped following this group to move on to other things. And so if you look at that group, again, there was 85% imaged. She could split these into two broad categories. The first is what she referred to as the traditional idiopathic syndromes, like 3 Hertz frontal lobe spike and wave. This is the one where, under the ILE classification, there was a lot of pushback because there was an attempt to try to take the term idiopathic away, but nobody wanted to get rid of it, so it's back. The other group, and if you notice, and not unexpectedly, that made up about a third of all the kids with epilepsy, of which only about 10% were considered drug refractory, using the 2-drug rule. Everybody else, which was the 365, nearly a third were drug resistant. If you then ask the question of those, how many had positive and negative MRI scans, In that idiopathic group, 97% were negative and only 5 were positive. None of the positive ones were drug resistant. Of those, and of all the other group, positive MRIs were seen in just over 20%, and those MRI positivities were things in the brain that are likely causing the seizures. So when people ask the question, should you be getting imaging in kids with seizures, the answer is if they're not in the traditional idiopathic group, there's a 1 in 5 chance that you're going to find a positive image that's related to their epilepsy, and that's the group in which half were drug resistant. So in fact, when we looked, if we split then between those with positive and negative MRI scans and asked the question, once they had failed 2 drugs, what was the chance of long-term seizure control with further medication? The answer was only 1 kid out of 36, 3%, had some sort of seizure control, and that was nearly 10 years out. So what's this tell us? You don't have to wait, and try every drug in the book to figure out if somebody's drug refractory. If you have failed 2 drugs and you have a positive MRI scan, the chance that drugs are going to control your kid's seizures is 3%, versus nearly 30% if your MRI is negative, which is similar to what the adult cohorts have shown. So the real deciding factor is, have they tried 2 drugs and is their imaging positive or negative? So further, if we take this group a little bit further and ask the question, so if we look at the in that cohort, then that non-idiopathic group, 33% were considered pharmacoresistant, i.e. they had 2 trials of 2 drugs, of which 15%, or nearly half of them, had some sort of surgical evaluation, but only 6% ended up having some sort of surgical intervention. So in the U.S. there's about 4 million live births per year. So the estimate would be that for kids under 16 years, there ought to be about 1,700 epilepsy surgery operations in the U.S. We don't know how many epilepsy surgery operations in the U.S. there are for kids because the national centers don't capture that data. And it seems I've asked several times, what's your last numbers? And they don't capture cases by age at surgery. So we don't know how many cases around the country are being done. My guess is it's not as much as it should be. All right, so what are the clinical characteristics of epilepsy surgery in kids? And this is going to be the result from the International League survey. So again, this was a group of people that have been working together now for over a decade, and we were able to collect data for the year 2004, so it's a bit dated now, but we got data from 46 centers from around the world, as you can sort of see. Most of these were North America and Europe, as you might expect, but we did have representation from Latin America, Egypt. The program in South Africa wasn't up and running at the time we did this, and then in Asia. And what are the results of that? So we were actually able then to collect over 1,000 patients in that survey to see what did the care. And what it turned out was that centers were more similar than they were different. Everyone expected there was going to be differences, and the reality was it was pretty much everyone was the same. If you looked, the age at seizure onset was early in the surgical cohort, certainly about 50% by the age of 2 years. Most in the first year of life. The epilepsy duration, though, before they had surgery, in the resective cases, though, often extended out many, many, many years. Remember I said the term was, we'd like to get the kids to surgery within 2 or 3 years of becoming refractory. That doesn't occur very often. We still don't get them in fast enough. Types of operation. Well, how many seizures a day? We didn't have a higher number than 1 a day, but you can see that 2/3 were having at least a seizure a day or more. Again, so it tells you we're treating the kids who are at the highest risk for the epileptic encephalopathy. Early onset, frequent seizures. The surgical workups were kind of what you would expect. There was a high, most everyone got MRI scans. Getting some sort of telemetry or video EEG was also pretty ubiquitous. And again, in 2004, the use of intracranial electrodes was right around 25 to 30%. The use of these other modalities varied again, and it depends upon the experience and the confidence that the center has in these particular modalities. If you look at the types of operations, not unexpectedly in some ways, focal resections and or lobar resections were about 2/3. And what you have a tendency to see in these surveys is that when programs first get started, they're often in places that already have adult programs, so they have a tendency then to reflect the adult etiologies, which then is temporal lobectomies. And so the early cases have a tendency then to be temporal resections or resections for tumors or real focal cortical dysplasias. The larger resections are ones in which when you start getting the kids much younger, especially under age 5 and under age 2. So that's where the variability comes through. Although still 20% of the series was hemispherectomy. The location was primarily frontal and temporal, not too different from adult epilepsy surgery. There's not a lot of adult epilepsy surgery in the parietal or occipital regions in most surveys if you look. The etiology? All right. A third were cortical dysplasia. Tumors made up another 20%. So between tumors and dysplasia, you're already half. And these other diseases that we think about as related to kids turn out to be pretty small, or at least on the list. Hemimeganencephaly, about 5%. Tuberous sclerosis, 4%. Rasmussen encephalitis, 3%. Sturge-Weber. And the vascular cases are a very, very small number of cavernomas that present and get operated on by the time the kids are like 12 or 13 or 14. Compare that against an adult series. So in an adult series, hippocampal sclerosis is the etiology that you deal with, and it represents 40-50%. Tumor is still number 2, often close to 20 or 30%, depending upon where you are, and whether the tumors go to the tumor guy or the epilepsy guy. So there are then dramatic differences. So let's take a little bit of a look at these different etiologies. So here's a case. See if you can figure out where the dysplasia is. So if you look, there's a heterotopic mass over here, and one that sits over here. The FDG PET scan shows decrease in that area. And then this is how I look at the brain surgically. So the eyeball is over here, temporal lobe, frontal lobe, here's the motor and sensory cortex. And this one doesn't look too bad. The cortical landmarks are pretty much where they ought to be and fairly normal. Contrast that with this case where there is almost a lissencephalic-like picture in the temporal and occipital area. Again, FDG PET shows you that. And then at surgery, you can see the wide gyrus and the wide gyri that proceed in that same distribution. Whereas in a severe case, here's a case of hemimeganencephaly. At surgery, in this case, there's barely any normal cortex. You can't even make out if there is something as a primary fissure between the motor sensory area. It's probably that cleft right in here. All right? Cortical dysplasia. What is it? Histopathologically, it consists of 2 main characteristics: dyslamination and disorganization at the cortex, and this is almost always associated with excessive neurons in the subcortical white matter. Imaging this Now, when it's big and bad, you can pretty much make it out. A thickened cortex, change in the underlying white matter, and graying of the gray-white matter interface, this is pretty clear. However, many of the times it can be subtle. So if you ever play the game Where's Waldo, so here's the question here. Where's the cortical dysplasia here? Look carefully. And if you look right there in the perihippocampal gyrus, there's an area of thickened cortex. And so this was a type 2 cortical dysplasia that was very subtle. Here's another case. Where's the cortical dysplasia? Well, here, if you look very closely, look at the thickness of the insula on the right side. So you have to look at the whole thing. And so if you have a child with very focal reproducible seizures and a very focal scalp EEG, I would say to you, there's a dysplasia there and it's your job to find it. If you haven't found it, it means you haven't looked hard enough. It's there. You have to go search for it. In fact, if you look at the literature and look at the question of how many series report normal MRI versus the percentage of mild or subtle forms of cortical dysplasia, you can see the whole flip-flop from one series in which they had a high rate of normal MRIs and then a corresponding high rate of milder forms of dysplasia versus others in which they never operated on anybody with a normal MRI and they never found any mild dysplasias. So mild type 1 cortical dysplasias are hard to find and you have to search for them. Now, from a research side, some years ago in the late 90s, working with Carlos Cepeda and the group of Mike Levine, we've been doing studies where at surgery, I take out a piece in the areas of interest. It gets taken across the street to the lab where it's cut, put into a chamber, and under infrared optics, they hunt and search and then poke and characterize the different cells. In the late 90s, the thought was that these large dysplastic cells that we were looking at had to be the epileptic neuron. But there was no animal model, so how could you really test that? So what we've found over time, and we've been able to sample several different types of cells. We've studied balloon cells, large neurons that are pyramidal in shape. We've discovered that something that hadn't been previously reported, and that was large cells that are GABAergic. So they're large cytomegalic interneurons, and then other cells which are very immature. Bottom line, the balloon cells look like glia, act like glia, respond like glia. They do not spontaneously discharge. You can pour kainate on them. They'll do a little oscillation, and that's about it. So they are not contributing to all this. And we've searched both in sclerosis or in TSC and in hemimegaencephaly. They don't respond. We have those seen occasionally, and very rarely, cells that have both neuronal and glial features. The bizarre cells that look like whether they were supposed to be neurons or glia when they were born. There are not many of those, and they actually act more like the balloon cells. The cytomegalic neurons, on the other hand, turn out to be a little bit more interesting. While they do not spontaneously fire, if you take them to firing potential, they will repetitively fire on if you take them to a depolarizing potential. And this can be blocked with cadmium, suggesting that these are voltage-gated calcium currents. But we've never seen one of these of the pyramidal shape fly on their own. The immature cells are a little bit more interesting. They're small, they're not as well developed, and many of them have spontaneously inward-going currents that can be blocked with bicuculin, consistent with the idea that in early development, GABA, it can be a depolarizing receptor. And if so, we've seen it in these cases of these immature neurons. And part of this, Veronique Andre was working in our lab, and she did some immuno work where she was co-staining for GAD and NUN, and she identified cells that were large that contained the enzyme for producing GABA. And she did some disassociated work and then some single-cell RT-PCR, and in the process was able to identify large cytomegalic interneurons that contain both GAD 65 and 67, and under electrophysiology, they too are interesting in that they were one of the few cells that have the capability then of firing and maintain a sustained firing. So, and these cells, they're not in all cases of dysplasia. We've only seen them in the type 2s and the most severe cases. So this is not a ubiquitous type of cell. If you look at spontaneous currents and then separate the tissue, just basically as to whether it's normal or severe, what you see is that in severe cortical dysplasia, there's fewer glutamate inputs as compared to GABAergic inputs. Again, consistent with so in early cortical development, GABA is the early signaling processing, and glutamate comes later. So with this, we proposed a concept that we think that cortical dysplasia is tissue that has been stuck in its developmental platform. It has gotten to a certain point and then failed, and we refer to this as the dysmature cerebral developmental hypothesis. These cytomegalic interneurons are interesting in that we've recorded at least a couple of these in which they fired spontaneously, but in a phasic way. They just off, off, which raises the question of whether they couldn't synchronize discharges and maybe more of an interesting culprit. And some of these cells are also interesting in that they have pacemaker capabilities. You record and they just spontaneously discharge on a very regular basis. So other etiologies. Well, here's a case of a temporal brain tumor. Again, this is fairly common in both adults and kids. In the low-grade tumors, it's important to remember that seizure-free after surgery does depend upon their status beforehand. Your best success is if they've never had seizures, but then if they're controlled, they still do pretty well, but not everybody. Here's a perinatal stroke, and at surgery it looks like this to me, big arachnoid membrane covering up these areas. Here's a case of tuberous sclerosis. This is an interesting case in that there were two twins, identical twins, so they're same genetics. One twin had infantile spasms and came to us. The problem with tuberous sclerosis isn't that not identifying what's the target, it's which of the many targets. And through a combination of work with our FDG PET and, in this kid's case, we took her down and she had a seizure in the MEG scanner. And it pointed directly to the tuber in question. And we were able to take her to surgery, and she's been seizure-free now for over a decade. Her identical twin came to me several years later because her SEGA began to grow. And this was before Afinitor was readily available. So I operated on the twin, but took out her subependymal giant cell astrocytoma. Hypothalamic hamartomas are again on that rare breed, but they're there. And there's been a lot of discussion about what's the proper approach here. I think this is one of the areas where laser ablation is probably best. And I think that with proper planning, that this is going to end up being probably the procedure of choice for this condition. Sturge-Weber. We don't operate as much Sturge-Weber as we used to. A lot of these kids become fairly well seizure controlled on current meds. But here's a case, and at surgery, this is what it looks like for me. All that telangiectasia, which can be gotten. And then One of the more devastating conditions is this thing called Rasmussen encephalitis, named after Theodore Rasmussen. This very progressive unihemispheric inflammatory process that we ought to be able to figure out a cause and treat, but so far haven't. And at surgery, it looks like this. All you see is basically some pale areas that are around. Now, what are the outcomes? From the survey, we were able to record about 55% completely seizure-free without auras in that survey. And so if you do the multiple analysis, what came down, the factors that influenced outcome were based on the following. If the pre-surgical MRI was positive, then, in other words, you had a target, which was 88% of the cases. There was a 58% chance of being completely seizure-free versus 29% if the imaging was negative. If the resection was complete, and this was left to the individual centers, hopefully this was based mostly on imaging, then the chance of seizure freedom was over 80%. So what it comes down to is find the target, remove it. It's pretty simple. If the target's big, it's a big operation. If the target's small, it's a small operation. An incomplete resection led to only a 16% seizure-free. And in the MRI negative cases, here again, if you were considered incomplete, seizure control rate was only 3%. In fact, I would argue that you have to have a pretty strong reason for operating on MRI negative cases based on, most of these are going to be intracranial electrodes. The outcomes, trying to find the bridge of the target without having something anatomic is a little bit questionable. Can you get better over time? Well, I had this woman from Argentina and Brazil that came to visit us, and we looked, and yes, indeed, what we've been able to show is that over time, at least in our program, we have had more success in making kids seizure-free. In other words, you can learn. And that includes kids that were completely seizure-free from surgery to those that did not gain any seizure control. We reduced that. So in other words, you can get better. We've looked at things like post-operative infections. We looked at 100 consecutive cases. We identified 16 infections out of that 100. Interestingly, only 4 were in the brain. The other 12 were not in the CNS. And fevers and elevated white counts were not good predictors of infection. The only real good predictor of infection was a positive culture. And those were linked with the larger resections. We've also looked at things like what influences getting kids to surgery. This was work that one of our colleagues who's now in Colorado. And what we found is probably not unexpected. Kids who were having active infantile spasms or previously treated infantile spasms had a high rate of getting in to be seen, and those that had daily seizures. Interestingly, a positive MRI by itself did not, while it was a factor associated with getting to referral, it didn't influence as much as you might think. And what was a bit of surprise is that in our cohort, if our patients were of Hispanic ethnicity, they got to us sooner, as illustrated in this graph here. And then if you look in that, so our private insurance did better than, obviously, state insurance, but our Hispanic kids with Medicaid actually did better than, the worst group was the Hispanic kids who had California Children's Services, or CCS as we call it. But that our input of kids with Hispanic origin has gone up over time. So we've actually improved that. So genetics, I'm getting almost done here. So the story here in the last few years has been this pathway, this PIK3 pathway. And in essence, in summary here, this kind of points to the factors that have now been identified that have been linked to the creation or the association with these things. The PI3K leads, and I'll show you that in a moment. There are spontaneous somatic mutations that lead to a gain of function in this pathway that can then lead to these enlarged syndromes. And we first suspected this when we looked at something simple like densities. We looked at cell densities in these different cases. And even visually, you can see here that at the top of the cortex in kids with cortical dysplasia, the density of cells was higher than expected in comparison to the lower layers. And if you then did the counts, cortical dysplasia was associated with a higher than expected density in the upper layers, suggesting that there was a problem then in late neurogenesis, producing more cells than was necessary. And in fact, when you look at cases like this in which there's this polymicrogyria, what you see is that the cell density at the upper layers is so dense that it seems to lead to the infolding of the cortex. So working with Joe Gleason down at UC San Diego, we did a study where using next-gen sequencing, because I've been saving tissue for a number of years. So we took tissue, did exome sequencing, then took a reference, in this case it was either saliva or blood, subtracted the two, and we found that now in 40% of our kids with hemimegaencephaly, we can identify a problem in the PI3K gene that affects somewhere in the neighborhood of 10-20% of the cells. It's a mosaicism. And this has now been confirmed in focal cortical dysplasias type 2. And we now have a handful of cases of tuberous sclerosis complex in which we've identified the second somatic mutation as the other allele in the TSC2 gene. Joe was able to go on and in putting a construct in a developing mouse brain, we've been able to recapitulate this by showing these markers. So that produces, by doing this in the cells, you can create cells with these enlarged dystrophic cells that you can actually rescue with rapamycin. So if you give the animal rapamycin, you can actually prevent it. If you then record from these animals, you can see EEG abnormalities that makes it hyperexcitable. And in a dish sequence where you can disassociate the cells and then culture them, these cells with the aberrant gene produce these large, giant cells with more dendrites than they belong. And linked with that, there's a pattern where the AKT can affect FOX gene, and the FOX gene then has an impact onto the under relin, so that the diseased cell begins to impact the cells around it, leading then to how you get this mosaic to affect large areas of the brain. So the last point I'll make is, as we go forward, and we're seeing more and more of the epilepsy syndromes being siloed, epilepsy is going to turn out probably to be a huge number of individual diseases. And at this stage of the game, you're seeing the creation of independent nonprofits that represent each of these patient groups. And I think as the physicians, we have a responsibility of working with these groups in order to understand their problems and how to move the field forward. I have the privilege of working with the Rasmussen's group, the Hemispherectomy Foundation, and I would encourage those who have never done it to look at TED, because there's a bunch of good ideas and talks there. And so finally,
Thank you for listening to my story.
because it's the kids that we're ultimately trying to do this for. And so I think this is the last slide I'm required to show if you're going to want your CME credit. And thank you for your time.
Thank you very much. Dr. Tami Tsushida from Children's would like to say that the talk was very informative and comprehensive. I would like to also express how impressive the scope of this talk was, very uniquely broad and beautiful and informative. We have a number of comments and questions. First, again, thank you for likening the encephalopathy to multiple rebootings of the brain. So this talk, in addition to streaming on the GW website, it also streams on epilepsy.com, which has a professional side and also a patient side. So I'm sure this was one of the easiest and most elegant ways to liken the seizure effect on the brain to computer freezing, and which can cause all interruption of the processing. Another comment is about underutilization of epilepsy surgery, which is a very important problem. Obviously, as in children, the earlier surgery can,
have an impact.
Save cognitive and social and motor function. In adults, there is also a lot to be saved by doing the surgery as soon as intractability is proven. And there are a number of papers, including ones that use the nationwide inpatient sample, that have shown no increase of utilization of surgery over time, which is a chronic problem that still requires intervention. Okay, now to go to the questions. Hemimegalencephaly is due to specific abnormalities in the mTOR pathway in a mosaic fashion.
It appears that we can explain a good portion of hemimegalencephaly as a spontaneous de novo mutation, yes.
Why does it affect only one hemisphere?
Don't know that. I mean, what you'd love to do, and unfortunately you're not going to get people to volunteer on this, is that you'd love to be able to ask the question, does the mosaic exist on the other side?
I see. Mm-hmm.
And with the exception of, we had one case at UCLA that died on the operating table, and that was years ago. And it was so long ago that none of that tissue was preserved for doing modern research like this.
Mm-hmm. Mm-hmm.
So the only way to answer that would be, it'd be lovely if there'd be a way to, if there are any SUDEP cases, to get our hands on those cases, because that's a beautiful question. But you got to have access to the brain, and you got to have it quickly in order to be able to test that. Because unfortunately, at the present time, there's no way to test for somatic mutations without studying the tissue that's diseased. Mm-hmm. You can't do a blood test. Mm-hmm. Mm-hmm. That technology so far doesn't exist. It would be wonderful if you could, but no one's going to sit down and say, I'll consent for you to take a brain biopsy of my kid's other hemisphere. Mm-hmm. So without access, you can't test the question.
Sure. We have another question, which I think you already answered. For SEGA and hamartomas, your optimal intervention, you mentioned laser.
For TSC?
Well, for the giant cell in particular.
The giant cells, I think Afinitor. So in TSC, the biallelic abnormalities are limited to a certain number of tissues. The SEGA, and the renal cell problems. Mm-hmm. So that would make the most sense to be responders to Afinitor. Mm-hmm. As far as the tubers themselves, I know there's a lot of interest and there's work in Europe and elsewhere to actually begin treating kids early, even before maybe they start having spasms with Afinitor. My personal experience is that I don't think it's may not be the tubers themselves causing the seizures. It could be the tubers and the surrounding brain, in which case the Venator is probably not going to be effective, and I don't think we're going to be getting rid of, I mean, if you can identify specific tubers that are producing the seizures, there's nothing short of take them out. It's pretty, as far as surgery is concerned, it's pretty straightforward. The risks are reasonably low, and if you get that seizure control, then you're good to go.
Another question: in pediatric non-lesional cases, normal MRI, do you use stereo EEG or depth electrode exploration?
I don't. As I mentioned in all this, I've had my personal bias from the get-go has always been that epilepsy surgery should be lesional. And so we should be pushing our technologies to identify the lesions. Stereo EEG has its limits. It has both a spatial and a temporal limit. And I personally think that we should be pushing our technologies. I think stereo EEG has its place, but I think it's more limited, especially as our imaging gets better.
Which actually brings us to the next question. You mentioned differences in the detection rate of dysplasias at UCLA versus the community. Is this related to the seizure protocol, or to the magnet, or to the reader?
Primarily the reader. I mean, at least at one point, most community hospitals have a good 1.5 Tesla system anymore, and most of those systems have the latest in software packages. It's usually the reader. And I will tell you that at UCLA, when we combined the co-registration, our radiologists got much better at reading the regular MRI scans because they detected subtleties that they found on the co-registration that they then could take on to other cases. So there's nothing that substitutes for experience. The more experience, the better.
Yeah, this is a software that we're trying to.
Well, Dr. Salomon will help you with it because it's pretty straightforward.
Yeah. I think I have maybe two more questions, quick ones. At what age do you think intraoperative language mapping could be done reliably without having to place a grid and do it extraoperatively?
Generally speaking, you got to get upwards towards 10. And 10 would be in a really cooperative person. It's scary. Think about it. I mean, you're sitting there in the operating theater, and to be awoken up and then to be able to have the cognitive processing ability to know to lie still and to answer the questions and to do the things that are necessary is a big task. And even 10-year-olds are going to struggle on that one. I mean, in my hands, it's usually, the intraoperative ones, it's been a little older. Certainly by the time you're 15 or on to 20, it's possible. But even then, a lot of coaching is needed. But what can replace that, I think, and what we haven't looked more effectively, is things like functional MRI for language. We've been doing more functional MRI, and as long as the resection is going to avoid Broca's and Wernicke's area and the arcuate fasciculus, we've been able to get by without any major problems. And but we have a very good functional MRI group that can get these kids to do some things. I mean, we've done functional MRI from motor down to the age of 2 successfully, which then avoided a grid.
Sure. Great. And last question, when you do hemispherectomy in the first year of life, regardless of does language develop similarly regardless of the lateralization?
Well, you can force language to develop on the opposite side, yes. So if you do it early enough, and by early, usually if you do that surgery before age 3 or 4, Language does pretty well. I mean, there are, if you do careful studies, you'll detect problems. But the kids can be very functional. As
Great.
long as the homotropic area on the other hemisphere is normal, and that is a key point.
Okay.
In other words, if you've got bilateral damage, be very careful about taking the left side and expecting that language is going to be normal. You really want the homotropic area to be pretty normal for the best outcomes.
Any questions from the room? I have a quick question. So, for those TS kids, like, how often do you think you can find those, like, identified with the major lesion? But a lot of times I find like MRI is like multiple focal, like all those lesions, and the EEG is everywhere, even that if you put enough.
Usually we find that as a problem when you get to older kids. In other words, when you get kids who've been seizing then for 7, 8, 9 years, at that point they generally start looking very generalized and more Lennox-Gastaut, and then it becomes difficult. Here again, we've been more successful if you can get those kids earlier, then the tuber or tubers usually become a little bit more mappable. Thank you.